Hi, it's Jamie Batts, your instructor for AMP2. We are talking about the respiratory anatomy. In the last lecture, we just finished talking about structures of the upper respiratory system. And in this lecture, we're going to continue with that and talking about, this is it, screen share, there we go, talking about structures of our respiratory system. We'll start with the larynx. So we just finished talking about the pharynx and the three parts of the pharynx. Now the larynx is also called the voice box. Remember, the pharynx is a fancy word for throat. The larynx is our voice box. This has three very large unpaired cartilages, so that they actually have specific names. And there's actually three small paired cartilages as well. And we'll go over some of these in lab, and you can recognize them for a practical. Unpaired cartilages include the epiglottis. The epiglottis is kind of shaped like a shoehorn. It's kind of curved up, and during swallowing, it folds down. This is that lid I kept referring to in the last lecture. It's the lid that prevents solids and liquids from going into the respiratory tract when you swallow. The thyroid cartilage is kind of shaped like a shield in front. This is the Adam's apple. You can almost feel it a little bit. You can hear my voice go a little crazy if I push it because I'm literally pushing on my voice box there. It forms the anterior and lateral walls of our larynx, and it's very prominent. It's also called the laryngeal prominence, the little part that sticks off, or Adam's apple. It actually attaches to the hyoid bone and the epiglottis and the smaller laryngeal cartilages. The cricoid cartilage is very ring-shaped. It's actually a complete ring of cartilage. Together with that thyroid cartilage, it's protecting the glottis and allowing for attachment sites for some of the muscles and ligaments in that area. So here they are, the cricoid cartilage, our thyroid cartilage with its laryngeal prominence, the hyoid bone, and the epiglottis. This is an anterior view. If we go to a side view, we have a really good model of this in lab. It's all very easy to see. You can see the ligaments, the vestibular ligament and the vocal ligaments in there. These are the ligaments that are vibrating as air passes over them to produce the sound of my voice. This is a posterior view of the structure. Pretty cool. Notice here, and we'll talk about this in subsequent slides, but notice the tracheal cartilages. From the anterior view, they look like they're complete, but from a posterior view, they're actually incomplete. They don't go all the way around. They are C-shaped cartilages. So we'll talk about that. Back to the larynx, though, you have these are the paired cartilages. The cuneiform or wedge-shaped cartilages are long and curved, and they lie within the folds of the larynx itself. The corniculate or horn-shaped cartilages function with that arytenoid opening and closing of the glottis, and the arytenoid cartilages articulate with the cricoid cartilage. You'll see these very easily in lab when we're talking about these structures in 2D. It might not make so much sense, but in lab you'll see them in the three-dimensional form. You can see the arytenoid, the corniculate, and the cuneiform cartilages all in this diagram. The cricoid, the thyroid, and the epiglottis as well, the unpaired. So the glottis itself has the vocal folds, which are just the kind of openings between the vocal ligaments. Those vocal folds contain the vocal ligaments, and this is obviously involved in sound production. The vocal folds are also known as the vocal cords, and the vestibular folds contain vestibular ligaments, and they're there to help prevent the incoming of foreign objects. This is when you get something down the wrong pipe, so to speak, and you cough it back up. It's because it's caught in those vestibular folds. So there they are. You can see the vocal cords, the vestibular fold, the part of the tongue kind of all the way in the back of the throat. You see the epiglottis folded back, and then you can also see the difference between when the glottis is open and when the glottis is closed. When it's open, that's when the sound is, when you're breathing, or when air is passing over that particular area. So let's talk briefly about how speech is created. There's really two processes in speech. The phonation, or the sound production, this is just the right, that's coming from the larynx. It's basically vibrations of those vocal cords producing sound waves. That's all it is. It's controlled by voluntary muscles. My brain, the speech center of my brain, is dictating down here exactly how tight or loose or deep or high, right, to make those sounds. The articulation is then the modification of those sounds. That's the pronunciation. That's done with the mouth, the cheeks, the tongue, the lips. As I'm talking, I'm moving my tongue. Speaking is very difficult if you cannot move your tongue. And then, of course, you have amplification and resonance that are going to occur within the pharynx, within the oral cavity, within the nasal cavity, within the sinuses, and that produces the actual sound of your voice. That's why everyone's voice sounds different, because all of our bones and spaces within our bones are different, because that is, in essence, what is allowing our voices to be different, how that sound reverberates and amplifies within that space. So you can pause the video here, go back and review these 3 questions. We're going to keep plugging along and talk about the windpipe, or the trachea, tough flexible tube, about 4 inches long or so before it starts to split off, has those C-shaped tracheal cartilages. The C-shaped cartilages are there to help support and protect the trachea from collapsing on itself. You obviously don't want it to pinch off. That would prevent any air from getting into or out of the lungs. It will also prevent overexpansion of the lungs themselves. The ends of the tracheal cartilages are connected by something called the trachealis muscle, which is going to allow for the expansion of the esophagus when you swallow. When you swallow, the esophagus is posterior to our trachea, and normally the esophagus is collapsed and it's kind of like a vein, right? There's no pressure in there. It just collapsed on itself. But when you're swallowing something, now you have something taking up space. So that esophagus is going to expand into that open area on the back of the trachea, which is why when you're eating, you're kind of regulating your breathing. You can't inhale and swallow at the same time. You're going to choke, right? So it's going to allow for that to happen. You have the trachealis muscle is going to allow for the tracheal constriction and dilation during sympathetic or parasympathetic innervation. So the trachea then branches at a spot called the carina. It's just the little kind of branching part at the end of the trachea, into right and left primary bronchi. So you have a primary bronchi on the right and a primary bronchi on the left. Each bronchi leads into the right or left lung. Most of the foreign objects that are going into the trachea will end up in the right primary bronchus as opposed to the left, and that's because the right is larger in diameter and it descends at a steeper angle, so it's easier for debris to get trapped in that right side. So there you see them. You can notice that difference between the right and left diameters just by looking at that diagram there. And here you see the flow of air through the respiratory tract. So it starts with the trachea. This is the lower respiratory tract, I should have clarified. Trachea splits off into primary bronchi. The primary bronchi branch off into secondary bronchi. The secondary bronchi branch into tertiary bronchi. And then we get to the bronchioles. The bronchioles will branch into terminal bronchioles. And from terminal bronchioles, they branch into the alveoli. There are some other terms you should be familiar with. Your book will use it interchangeably as well as tests and quizzes. So the secondary bronchi are also sometimes called the lobar bronchi. The tertiary bronchi are also called the segmental bronchi. So primary bronchi, lobar bronchi, segmental bronchi, and bronchioles, just for substitution's sake. And you'll see those terms segmental and lobar again in other systems, which is why I think it's good to be familiar with them now, because they're used almost in the same way later on. Let's talk about our bronchioles. Overall, they lack cartilage. So we had a very cartilage-intense lower respiratory system at the boundary of the lower and upper respiratory system, right? Our larynx, our trachea, our primary bronchi, very cartilage intense, lots of cartilage. Now, as we go through the lower parts of our respiratory system, you're going to see a trade-off. Less cartilage, more muscle. There's going to be more smooth muscle in this lower portion than in the upper portion. So there's relatively thick layers of smooth muscle within the bronchioles. So under sympathetic innervation, this is going to cause bronchodilation, right? Sympathetic, fight or flight, heart rate respiration increase, right? So your bronchioles are going to expand, allowing for more air to come in, allowing for more gas exchange, allowing for more oxygen, right? Getting that oxygen to the lungs, all of that kind of going together. The relaxation of the muscle, increased diameter of airflow, that's how that works. Parasympathetic innervation is going to cause bronchoconstriction. This would be, contracting that muscle, decreasing the diameter, decreasing airflow. During extreme bronchoconstriction, this can occur during allergic reactions like asthma. So there's two types of bronchioles. You have terminal bronchioles, which come from the tertiary bronchi. These terminal bronchioles lead to pulmonary lobules. These pulmonary lobules is where gas exchange takes place. You also have respiratory bronchioles. Respiratory bronchioles are after the terminal bronchioles. So here you see the kind of branching as it takes place. You have your primary bronchus, secondary bronchus, tertiary bronchus, or bronchi, right? It's just singular or plural is the different ending. From the tertiary, we're going to branch off into the bronchioles. You have a terminal bronchiole and a respiratory bronchiole. The terminal bronchioles branch to form what's called a pulmonary lobule. The pulmonary lobule contains the respiratory bronchioles. Make sense? So here's just a cross-section of a bronchiole. You can see the respiratory epithelium as well as the smooth muscle. So let's follow the airflow and diameter changes through the trachea and bronchial branches. From the trachea, we go to the primary bronchi, to the secondary bronchi, to the tertiary bronchi, to the bronchioles. The terminal bronchiole to the respiratory bronchioles to the alveoli, right? The respiratory bronchioles and the alveoli make up that pulmonary lobule. The bronchi branch into smaller and smaller tubes. At each new branch, the diameter is decreasing, right? So overall, we're getting a huge decrease from trachea to terminal bronchioles. You can pause the video here, go back and review this section. Let's talk about the gross anatomy of the lungs in terms of the bronchial tree. So you have two primary bronchi. These lead into our two lungs. Each primary bronchi branches off into something called a bronchial tree. Right? The primary bronchi branch to the secondary bronchi and then the tertiary bronchi. I think we covered that already, right? It's pretty straightforward. But each tertiary bronchus is going to supply air to a specific region that's called a bronchopulmonary segment. It's basically like the area that is supplied by that particular tertiary bronchus, right? Kind of like their little zone. So here you see, and it's color-coded to help you. You have bronchopulmonary segments of the right superior lobe, of the middle right lobe, and of the inferior right lobe, and the left superior and left inferior lobes. Each lung is divided into lobes, and the right lung has 3 lobes, superior, middle, inferior. It's divided by a horizontal and oblique fissure, which we've already identified in lab, so you should be a little bit familiar with this. The left lung has 2 lobes, just superior and inferior, and just has an oblique fissure. The cardiac notch is on the left side, is on the left lung, and this is obviously to make room for the heart. It's just a little notch that's taken place. The lobes are then subdivided into those bronchopulmonary segments that we referenced earlier, and each lung is surrounded by a pleural cavity. Pleural cavity is lined with the pleural tissue, the serous membrane. Here's an actual cadaver picture of the lungs so you can see what they look like. In that space, you can see that it's not labeled. Cardiac notch is this little notch that's basically been taken out of this left lung here. See how black it is, right? Then lungs aren't supposed to be black. They're supposed to be nice and pink. And that black is obviously there from all of the environmental toxins that have been breathed in over a lifetime. So each lung is basically like a blunt cone, not a pointy cone. The tip extends to the top part of the first rib. So remember how our heart had the base at the top where all the great vessels were and the apex was down and pointing toward the left? Well, here our lungs are flipped around. The base is the concave inferior portion that's resting on top of the diaphragm, and the apex is the pointy superior portion. Here you see our lungs, superior, inferior, middle lobes, cardiac notch on the left side, apex on the top, base on the bottom. Other lung terminology, we have a hilum. We've heard this word before. We talked about a hilum when we talked about the spleen in the last chapter. Remember, and a lymph node, I think. The hilum is a point of entry for vessels and structures. So each lung has a medial depression, and this is the hilum. This is where the primary bronchi, nerves, and vessels and lymphatics enter the lungs. The root of the lung is the actual connective tissue that holds everything in place. There are grooves marking the position of all of the great vessels on the medial surface. So you'll actually see when you look on a lung where all of these things are, just like this. Right? Medial surface, you see the hilum is just the general area and indentation where all of these vessels and structures are entering into the lung itself. See if there's any other. The root is just the connective tissue that surrounds this particular area. So you can pause the video here, go back and review this section of lung anatomy. Let's talk about the pulmonary lobule itself. This is supplied by the terminal bronchiole. Each pulmonary lobule is only supplied by one terminal bronchiole. The terminal bronchioles will branch into respiratory bronchioles. The respiratory bronchioles are basically the beginning of the respiratory portion of the respiratory tract. Within the respiratory bronchioles, we have alveolar ducts leading to the alveoli. So here is a better picture. So the whole bronchopulmonary segment includes the tertiary bronchiole, the terminal bronchioles, the respiratory bronchioles, the alveoli. Our pulmonary lobe just includes our respiratory bronchiole and the alveoli. From the respiratory bronchiole, you have alveolar ducts. Those are just the little passageways out to the alveoli, and then the alveoli themselves are the little bubbles that you see in this picture. So they're supplied by an alveolar duct. They're attached to a chamber. Sometimes it's called an alveolar sac. So going back to this picture here, you have 3 alveolar sacs, just to give you a frame of reference, right? There's approximately 150 million of these per lung. So this is giving the lung a very spongy appearance because there's all this open space inside of it. Huge capillary network surrounding these alveoli, allowing for gas exchange to occur. And there are lots of elastic fibers to hold everything in place. This also allows for the expansion and recoiling that happens with the change in volume that our lungs undergo every time we inhale and exhale. Our lungs are surrounded by the pleura. It's a serous membrane, so there's a visceral and parietal layer. The visceral layer is covering the outer surface of the lung. It doesn't have a special name, it's just called the visceral pleura. Like in our heart, it was called the epicardium. Here's just visceral pleura. Parietal pleura is covering the inner surface of the pleural cavity, going over the diaphragm and mediastinum. And the pleural cavity has pleural fluid to reduce friction as the lungs move in size, right? Here's a really cool picture showing the vascularization of the respiratory system. So you have the pulmonary artery, you have it lined right up with the bronchiole, and you can see the branches of our pulmonary artery branching down into these capillary beds which are surrounding these alveoli. The alveoli air sacs, strongly innervated or vascularized by these branching blood vessels to allow for this exchange to take place. You can also see in this image the pleura, visceral, parietal, and the space where the pleural fluid would be. Notice there's also lymphatic vessels in the tissue area, and you can also see some of the elastic fibers. They almost look like rubber bands surrounding the alveoli. There's elastic fibers to allow them to recoil and maintain their shape. The alveolar epithelium contains three main types of cells. Most of the cells within the area are simple squamous. They're also called type 1 pneumocytes. They're very thin, delicate cells. This is where gas exchange actually takes place. The type 2 pneumatocytes, these secrete something called surfactant. Surfactant is a secretion to reduce surface tension of the fluid within the alveoli. So it's there to help allow for that gas to exchange as well as prevent the collapse of the alveoli themselves. There's also alveolar macrophages called dust cells. These are little Pac-Men that go around and phagocytize anything that could clog up, block, or try to destroy the alveoli. Here you see them. The purple cells are the type 1 pneumatocytes. The type 2 pneumatocytes are the little spiky looking cells, and the macrophages, there's just a few in there. They just float around and gobble up anything that doesn't belong. The respiratory membrane itself is the actual site of gas exchange. So this is very, very thin to allow for very rapid exchange. As thin as 1/10 of a micrometer. It's very, very, very small. There's three layers to it. So think of it kind of like a sandwich. You have the alveolar epithelium, right, that inner lining of the alveoli. There's a fused basement membrane, and then the capillary endothelium. An epithelium, a basement membrane, an endothelium. So the gas has to come in, go through all of those passageways, dissolve in the surfactant, dissolve into the alveolar epithelium, pass through the basement membrane, pass through the endothelium, and then it is in your blood. And then the blood sweeps it over to the heart, right? Or the vessels sweep it over to the heart and it gets pumped around. Crazy, all that work just to breathe. My goodness. Here it is. You have your alveolar space covered with the surfactant to allow for the dissolving of those gases, alveolar epithelium, fused basement membrane, capillary endothelium, capillary lumen, or the space, and here you see the red blood cell, which is there to grab up all of the oxygen that's coming in. You can pause the video here, go back and review these three questions. We're going to keep chugging along. There are some special reflexes that are involved in our respiratory system. They're called baroreceptor reflexes. These, that's right. Yeah, this is just maybe just a little out of order. Sorry about that. Let's talk about it on the slide, and then we'll look back at that picture. That might help make a little bit more sense. So we do have some reflexes that are involved in respiration. There's an inflation and a deflation reflex. This is activated by special stretch receptors that will be activated during breathing. So there's something called tidal volume, which I know we haven't quite talked about yet. We'll do that in the second section of this chapter. But tidal volume is just the amount of air that we're breathing in just quietly as we're sitting here, right? Not exercising, not sleeping, just living, right? So if that volume is increased for whatever reason, special sensory information will be distributed to what's called I had a feeling this is totally out of place. This is 21.17. I was like, this is an awful lot of information of stuff that we have not talked about yet. So I'm going to stop the video here, figure out what the heck's going on with my PowerPoint, and there may or may not be another segment for this section. See ya. Sorry about that.